Thank you, Doctor, and good morning, everybody. It's really my privilege. I'm going to stand here. If I speak like this, can you hear me? I think it's easier to do like this. Otherwise, I have to sort that. Okay. I'll talk like this. Good morning, everybody. It's really my privilege to be here this morning. What a fantastic audience, and it's really great to see people from different disciplines, from the clinical side, the biomedical side, and the public health side, because one of the really important things about NCDs is that it's such a multidisciplinary field, and it needs people from right across public health and medicine, but also a range of other disciplines, people who understand finance, people who understand technology, people who understand the law, to come together to find solutions to this tremendous global health challenge. So as Dr. mentioned, NCDs now are the cause of death of about 2/3 of all people in the whole world. But often people don't understand the extent of the challenge. I think the big problem is that, in many parts of the world, infectious diseases, maternal and child health conditions are still very important, very significant, and this includes in Indonesia. But in a global scale, there's still a lack of understanding about the challenges of NCDs and the responses required. So my talk today will provide an overview of the risk factors and the diseases, and then I'll talk a little bit about the responses that are needed at community level, within families, at national level, and internationally. So this morning, I suppose I'm wearing my University of Melbourne hat, and then later on I'll put my Victorian government hat on and be a bureaucrat. So I'm in Indonesia for about 3 weeks. The purpose of my visit is to look at opportunities for Victoria's health system, so right across our hospitals, our universities, our government and other stakeholders, to engage with Indonesia to find solutions together to public health challenges and medical challenges. So I'm sure many of you know about the way WHO categorises NCDs, but when I talk about NCDs, mostly I'm talking about the 4 main disease groups. So I'm talking about cancers, diabetes, cardiovascular diseases, and respiratory diseases. But within the agenda of NCDs, often we're talking about mental health, dementia, accidents, and some people include other diseases in this group, but anything that's not communicable. And of course, there are very strong links between mental health and chronic disease. We know that people with mental health conditions are more likely to have risk factors like too much use of alcohol or a higher rate of smoking. We know that some of the risk factors that lead to dementia, to Alzheimer's disease, are also risk factors that cause NCDs. And the reason we talk about the 4 main disease groups is that when we talk about prevention, so many of these diseases, so many of incidents globally can be reduced, can be prevented by 4 main areas of prevention. We know that if we reduce tobacco use, that if we improve people's diets, so if we get rid of junk food and sugary drinks, if we get people more active, and if we reduce the harmful use of alcohol, that we can reduce a significant level of NCDs. We know that 80% of heart disease, stroke and diabetes, and more than 40% of cancer is actually preventable. And one of the great misunderstandings about NCDs is that people often think that they're diseases of the developed world, so countries like Australia or the United Kingdom. But the truth is that everywhere in the world, except Africa, NCDs are the dominant cause of mortality, so the biggest cause of death. This is certainly the case in Southeast Asia, in the Pacific Islands, which is a region I've spent a fair bit of time. There are tremendous challenges associated with particularly overweight and obesity. And even in Africa, as development continues, NCDs are starting to increase rapidly. So I'll talk a little bit about the specific diseases and disease groups. So this graph just shows the very rapid increases in levels of diabetes worldwide. And we can see that in right across the world, but particularly in low-income and lower-middle-income countries, there are huge increases and rates are nearly doubling over the space of about 20 or 30 years. And this is all largely due to lifestyle. So in a global sense, cardiovascular disease is the number one cause of death, with about nearly a third of all global mortality, and the majority of which is in low and middle income countries. And as many of you would know, high blood pressure is a huge cause of CVD and itself a major risk factor. Chronic respiratory diseases are a significant challenge. Chronic obstructive pulmonary disease, asthma, occupational lung diseases, and pulmonary hypertension. And those risk factors, I'm sure, won't be a surprise to you. And I've included dementia here because it's particularly in ageing populations, and Indonesia is an example of an ageing population. Over the next decade, the next 20 years, what we're going to see is dementia going like that. And as I mentioned before, some of the risk factors for dementia are very similar to the risk factors for the other NCDs. Something in other meetings I had last week on the topic of mental health, some government officials in Jakarta were talking about the fact that people with dementia in Indonesia are not diagnosed properly sometimes and are mistakenly thought of as having psychosis or depression. So I think it shows you the importance of proper diagnosis and of understanding these different disease groups. Is everybody familiar with the Global Burden of Disease study? Excellent. So this is probably my favourite resource in terms of understanding national health trends and international health trends. But I wanted to illustrate some of the points I'm making by referring to the GBD data. So this is top 20 causes of death, 1990 and 2010 worldwide. And generally speaking, what we can see is a reduction in the red lines, so a reduction in infectious diseases, maternal and child health diseases, communicable diseases, and an increase in heart disease, stroke, pulmonary disease, and cancers. But what we can also see is that even back in 1990, on a global scale, heart disease and stroke were the two dominant killers. So this is an expression of yearly lives lost, which is a way of understanding premature mortality. So people dying younger than they should. And what this shows as well over the space of 20 years is a huge shift to people dying too young from heart disease, stroke, and increasingly lung cancers, cirrhosis, and diabetes. I thought it would be interesting as well just to look at the difference in premature deaths between Australia and Indonesia. because while there are actually some similarities, you can also see that in terms of the epidemiological transition, you can sort of see where Indonesia is heading to, along with many other countries. So it's pretty obvious that in Australia, NCDs are the biggest burden on the health system, the biggest cause of death, and the biggest cause of death among young people. So ischemic heart disease, lung cancer, stroke, and types of cancer. What I will point out is that road injury has been significantly reduced, and the way that's been reduced has been through lots of individual measures, lots of different regulations and laws, lots of different public communications initiatives, health promotion initiatives, because certainly if you go back 20 years, 30 years ago in Australia, too many people were dying on our roads. That's still the case, but the trend has reversed. And this is premature deaths in Indonesia, and the thing that two things jump out at me. So the increase in NCDs has been really significant over that 20-year period. But unlike Australia, the dual burden of disease in Indonesia is much stronger. And so this has real implications for health promotion and for the health sector. Traveling, I visited some hospitals in Jakarta last week, and was given a very tangible understanding of the health systems having to deal with chronic diseases, but then still having significant challenges in terms of particularly tuberculosis. And so in many, many parts of the world, particularly low and middle income countries, health systems are having to deal with all of these different factors. So the unfinished communicable disease agenda, so all of the things that the Millennium Development Goals sought to address, are in many places still not under control. We have maternal and child health problems, NCDs, and accidents and injuries. I want to talk a little bit about tobacco today, because I think everybody here would understand how much of a challenge it is in Indonesia and how much of a challenge it is globally. I understand as well it's a big political challenge. I think this is a country where the most wealthy person and for the past 10 years has been the owner of the biggest tobacco company. And with this brings a tremendous amount of influence and power. And tobacco companies increasingly have shifted their attention from developed countries like Australia to developing countries like Indonesia. This is just some data about rates of smoking. What we see in a global sense across the world is that some countries there's been significant reductions in tobacco use and the harm of tobacco, and in other countries rates are increasing really, really dramatically. And I wanted to also highlight overweight and obesity. What we've seen, and for me, along with tobacco, this is the dominant global health problem. In Australia, this is our number one problem. About 2/3 of all people in Australia are now overweight or obese, and that has happened incredibly quickly. It's happened over about a 20-year period, and that's due to a complex range of factors. And this stat might surprise a lot of people because I think there's not a lot of awareness in some parts of Southeast Asia. But what we're seeing is a really, really fast increase in levels of obesity. So what we're seeing is big food companies, big soda, so soft drink companies, doing the same thing that tobacco companies are doing. This is as incomes rise, as more people have disposable income, more people are eating unhealthy food and drinking unhealthy drinks. If we look at percentage of obese adults from 2010 to 2014, we've seen really concerning, really rapid rises right across the ASEAN region. And of course, in a country like Indonesia, I understand that stunting and malnutrition are huge ongoing challenges as well, particularly in more remote provinces, more remote cities. But and in a global sense, this is also the case. But what we're seeing is that the food agenda, the issue of nutrition is more and more complicated, because even in the same communities, we're seeing stunting and overweight, even among neighbours. And so our preventative health programs, and so our health system responses need to be mindful of this complicated issue of nutrition, underweight and overweight, occurring simultaneously. And I mentioned at the start of my talk that the global health agenda, so governments, so the big bilateral and multilateral aid donors, have really focused on communicable diseases, maternal and child health conditions, HIV, TB. And this was really important. But what we saw in the Millennium Development Goals was that NCDs, so the risk factors or the diseases, were not mentioned once. And this was despite the fact that when the MDGs were developed, NCDs were already the #1 killer worldwide and increasing really quickly in low and middle income countries. The consequence of not having NCDs included in the MDGs was that global health funding, all of the political momentum continued towards fighting infectious diseases, and largely disregarded, largely ignored NCDs. And so funding for health within countries or at an international level simply did not did not adequately respond to the true nature of disease burden. The good news is that the global health agenda has shifted, and so I think increasingly within countries, within communities, at the international level, there is an understanding of the burden of NCDs. So this has been reflected in the WHO strategy for addressing NCDs, which is a voluntary strategy for countries, but still has significant political weight and shows the WHO's commitment in this area. And the goal of WHO is to reduce premature mortality from NCDs by 25% by the year 2025. There's a range of other targets there as well, which I think if they're all achieved over the next, how long have we got? 7 years, I think the overall burden of NCDs will be significantly shifted. And of course, the other major global health governance political movement is around the Sustainable Development Goals. So the SDGs replaced the MDGs, and the good news is that NCDs are included, are very prominent within the framework of the SDGs. This reflects a better understanding of the evidence, but it also reflects significant advocacy within countries and internationally by groups like the NCD Alliance, by academics, by NGOs. And so the SDGs have a similar target to reduce mortality from NCDs, to focus on the harmful use of alcohol, to achieve universal health coverage as well. And I think that the shift in Indonesia towards JKN health coverage is a really important shift, and I think it's an excellent thing to see. Though I understand that in some areas it's controversial and there's challenges in rolling out GADJAH the FCTC as well. And so I think Indonesia still remains one of the only countries worldwide that hasn't become a signatory to the FCTC. And that is reflective of the political challenges in Indonesia around particularly tackling the tobacco companies who are so influential. But the FCTC is really a framework that countries can use for regulations, for health promotion initiatives to address tobacco control. In Australia, our tobacco control efforts have been largely aligned with the FCTC, and what we've seen is a steady decline in the harmful use of tobacco. Of course, vaccines and medicines, particularly in developing countries, are very important as well. So I want to talk a little bit, mindful that I'll run out of time in 8 minutes and 50 seconds, but I want to talk a little bit about the responses that are needed. So not only looking at communities, looking at countries, and looking in a global context as well. When I think about NCDs, I like to think about different systems. So, and having a group here from different areas of the health sector, I think is really useful in thinking about. So obviously we have the health system, and a lot of the responses to NCDs will be embedded within the health system. Also food systems. So understanding what we eat, understanding that, in Melbourne, if I walk into a supermarket, I have to walk past chocolate and chips and Coca-Cola. When I walk into a supermarket, my 3-year-old son has to walk past chocolate, chips, unhealthy food everywhere, and it's simply impossible to avoid. So when I go to the checkout, I'm putting my vegetables and my fruit, giving them to the checkout person, and I'm surrounded by chocolate. And so understanding the role that supermarkets play, understanding the role of multinational companies, McDonald's, Nestle, in influencing what we eat, understanding that when we turn on the TV, if we see a commercial for McDonald's, understanding the influence that has. And legal systems. So a lot of the responses to NCDs are through law and regulation, reducing the ability of tobacco companies to sponsor sporting events or promote themselves to our children. I was walking near my hotel yesterday, and I saw a big billboard for a tobacco company that looked like a video game, and I thought it was an advertisement for a video game, but it was actually an advertisement for a cigarette. And it was very obvious that they were targeting children. And that's something that you cannot do in Australia, and I hope that the environment in Indonesia shifts in the coming years to at least protecting young people from these sorts of harms. So at a local level, there's a lot that can happen. It can happen within communities, it can happen within local governments, local health centres. Urban planning is incredibly important. So for me, I was in Jakarta for about 10 days, and I've spent time there in previous years as well. And it's impossible to walk around. It's impossible to get exercise. To even walk to the shop from my hotel, I had to cross 4 lanes of traffic. And it's simply not safe, and there's no parks. I contrasted that when I got into GADJAH last night. I was able to go for a nice walk around my hotel, get a little bit of fresh air, a little bit of exercise. It was a much more friendly neighbourhood for helping me be healthy. I've talked about supermarkets, but every single person that owns a supermarket has the option of promoting healthy food or unhealthy food. And that's a choice, and that's something that even as health professionals, as public health professionals, you have the power and the influence to advocate, to talk, to communicate about these other stakeholders. Transport is incredibly important, and particularly having the option to take public transport. At the end of the day, if you take public transport, you can at least have to walk to where you get the transport. So you can combine active transport, inactive transport. If you have to take the car from your, front garden to work, you're not getting any exercise during that process. Schools are really important as well. So obviously young people are the future, but habits start in school. Education starts in school. So offering healthy food to young people, providing opportunities for physical activity are really important. And religious settings. So when I worked in Tonga in the Pacific Islands, one of the main groups advocating for healthy lifestyles was the Catholic Church. So most Tongans are Christians, and certainly when they went to church on Sundays, a lot of church leaders talked about the importance of healthy lifestyles. And I think in different countries, the opportunities might be there for religious leaders to advocate around health as well. And so looking up a level to state and national, health policy is important, and particularly the choice that health policymakers implement around funding for prevention. And so in Australia, the vast majority of funding in the health sector still goes into hospitals and health services, and only a tiny amount gets spent on prevention. In Victoria, this is something that we're trying to shift, but it's still really difficult to shift funding from prevention to hospitals because your average citizen, most people care more about, it's more tangible and more obvious. If you have to wait to go to hospital, you're going to care more about that than if you see health promotion messages. Taxation is incredibly important, so taxation on cigarettes, taxation on unhealthy foods. One of the big advocacy pushes in Australia from healthcare professionals and NGOs is for a tax on sugary drinks, so a tax on Coca-Cola, on these kind of drinks, which are incredibly detrimental, incredibly bad for people's health. We haven't got there yet, and the government is very reluctant to implement a tax on unhealthy drinks, but in some parts of the world there are already taxes on unhealthy drinks, and I think that in the coming years we will start seeing more of a shift in countries in that area. Obviously, food labelling, so state governments, national governments are able to regulate, able to implement laws about packaging on food in the same way that they can make laws about packaging on cigarettes. There are some really interesting initiatives happening in different countries to ensure that people understand how healthy the food is that they're buying from a supermarket. Regulation around advertising is also important to ensure that these big companies can't advertise to children or can't sponsor sporting events. And that's something we've been successful at in Australia when it comes to tobacco. And of course, social marketing campaigns. So in Victoria, in Australia, we have an anti-cigarette campaign called Quit, which includes outdoor advertising on billboards, and includes information in health centres, commercials on TVs, websites, and also a hotline that people can call if they wish to, if they know that smoking is bad for them, but if they don't know how to change their behaviour or how to quit cigarettes. And of course, international. So I talked about the global context already, but certainly the SDGs and the WHO framework have really illustrated the changes happening at a global level and the importance of evidence and advocacy. Particularly for the public health people here, but also the clinical people, health promotion is incredibly important. And if we look at the WHO's priority actions for health promotion, we can see that NCDs, prevention and control, fits into each of these categories. So public policy, environments for health, community action for health, personal skills, so people's ability to understand their behaviour and their choices, and of course, health systems. Now, I'm going to skip through a few slides because I'm aware that I've gone over time a little bit. This is, in Australia, we're just starting to get organised about addressing overweight, and I talked about the reasons for that already. But what really needs to happen in Australia is that we need to look at our success in tobacco control and translate that into actions to address overweight. So taxation on unhealthy foods, subsidies for healthy foods as well, so that people can eat fruit and vegetables and fresh fish more cheaply. Limits on advertising and food labelling that's driven by public health and not by Nestle and the big food companies. And to finish up, I'll briefly touch upon health systems responses, so moving away from prevention to health systems. And many of you will be familiar with the WHO's building block system around strengthening health systems. And of course, service delivery, health workforce is very important, so ensuring that we have a health workforce, both in terms of clinicians, but in terms of allied health staff, in terms of nurses, in terms of hospital managers who understand chronic disease and can work as a team to address chronic disease. Health information, medical products, vaccines and technologies, health financing as well. So the increase in chronic disease is putting pressure on health systems, and there needs to be funding specifically for addressing NCDs. And leadership and governance. And for me, the big issue around leadership and governance is multi-sectoral action. So it's people from the health sector working with people from town planning and local governance and lawyers and educators in schools to find solutions that holistically address NCDs. So I hope that was interesting. These are significant problems that face both Indonesia and Australia. Some of our problems are similar, some of them are different, but certainly it's been my pleasure to talk to you, and I'll now hand over to our colleagues and we'll have some discussion. Thank you.
Thank you, Sam, for that excellent presentation, a comprehensive overview of the global perspective NCD. Now we're going to bridge that presentation, zoom in more into the Indonesian context. And to do that, we will zoom in, we will bring in one of our experts in NCD. We have Dr. Fatwa Asari Dewi. She's going to explain to you the perspective of NCD from a national and from a local perspective. Dr. Fatwa, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the time, Pak Yodi. And I hope Mr. Paivil do not mind if I'm speaking in Bahasa. Do you understand Bahasa? But you can see my presentation in English. If you want to read it, you are very welcome. And we already discussed about it a little bit this morning. Ya, oke. Selamat pagi, Bapak Ibu semua. Gimana kabarnya hari ini? Ya. Jadi pada pagi hari ini saya akan mendiskusikan sedikit tentang bagaimana pengendalian NCD dilakukan di Indonesia khususnya dan juga di Yogyakarta. The outline of my presentation, there will be 3 items. Jadi yang pertama adalah beban NCD, burden of NCD. We will compare between different monitoring system that exist in Indonesia. And then we will discuss about evidence-based policy and data scarcity. And finally, we will discuss a little bit about what to do to tackle NCD. It is a systematic review that we did last year. Ya, ini we have some sources. There are 3 sources. Ada 3 sumber yang kemudian mendasari presentasi saya. Yang pertama adalah dari Riskesdas tahun 2013, Basic Health Survey. Jadi dalam Riskesdas ini ada sumber yang kemudian secara official ini mensurvei kondisi di Indonesia secara keseluruhan. Ini sudah resmi, kemudian bisa kita akses dengan mudah. Dan tingkat nasional. Kemudian yang satu lagi adalah Riskesdas yang tingkat provinsi. Jadi kita bisa mengamati dalam setiap provinsi bagaimana, dan ini yang saya ambil adalah provinsi DIY di Yogyakarta. Nanti kemudian kita bisa memperbandingkan dengan kondisinya di Sleman. Kondisi di Sleman akan kami ambil dari sumber dari data yang tadi, data yang ini. Riskesdas yang sebelah kanan, jadi yang di DIY, dia akan melakukan perbandingan sampai ke tingkat kabupaten, begitu. Dan juga kita memiliki satu dataset, lari sendiri ya, ya. Dataset Health Demographic and Surveillance System. Jadi ini saya diberi amanah oleh Pak Yodi untuk melakukan suatu sistem pemantauan demografi dan kesehatan di Kabupaten Sleman. Kita melakukan pemantauan setahun sekali. Once a year we survey the population. There are about 20,000 individuals that we survey, including in around 5,000 households. Dan sekarang kita memasuki the 4th cycle, jadi kita masuk dalam siklus yang keempat. Jadi setiap tahun kita turun ke lapangan untuk mengumpulkan data-data tersebut yang meliputi data yang bersifat demografis, kemudian data epidemiologis, epidemiological data which is included major diseases in the population, including the communicable and infectious and non-communicable disease. We have them, and also about healthcare situation. So we have that data, and the other source, sumber yang terakhir ini adalah kita melakukan systematic review berbagai penelitian yang tentang NCD yang sudah dilakukan di Indonesia. Kemudian kita melihat bagaimana hasil dari penelitian tersebut. Kemudian kita itu dalam pengendalian NCD dalam hal ini sudah sejauh mana. Apa-apa saja yang kemudian perlu untuk kita tekankan ataupun kita arahkan. Jadi ini tulisan dari Bu Julia, salah satu PhD di Swedia. Now we go to the burden of NCD. Kalau kita melihat morbiditasnya, tadi sudah dipaparkan oleh Pak Sambaivil bahwa Indonesia termasuk yang kemudian terbebani oleh NCD. Dan juga kita amati kalau Yogyakarta, Provinsi Yogyakarta dan juga Sleman, Kabupaten Sleman, ini memiliki umur harapan hidup yang tertinggi di Indonesia. Sehingga akan mengalami masalah NCD ini lebih awal daripada provinsi dan kabupaten-kabupaten lain di Indonesia. Jadi seharusnya kita yang di Yogyakarta lebih concern untuk mengendalikan NCD dibandingkan dengan provinsi maupun kabupaten yang lain. Kalau kita lihat di sini dari morbiditasnya, ini terlihat bahwa dibandingkan dengan Indonesia, maka Yogyakarta hipertensinya lebih tinggi. Meskipun di Kabupaten Sleman masih sedikit di bawah Yogyakarta. Kemudian diabetes mellitus, ya di Sleman ini termasuk salah satu juaranya rupanya. Ya Yogyakarta juaranya karena seperti kita ketahui kita juga suka makan makanan yang manis di sini. Ya, Bapak Ibu saya yakin juga sudah suka makan makanan yang manis ya di sini ya, dan juga makan sambal mestinya. Oke, kemudian stroke masih sebagai pembunuh utama, kalau dari pengamatan penyebab kematian, pembunuh utama adalah stroke dan cardiovascular disease. Jadi dua data yang di sebelah kanan ini adalah perbandingan, yang sebelah kanan adalah dari HDSS, siklus tahun 2016, sedangkan yang sebelah kiri ini adalah hasil dari Basic Health Survey. Jadi Riskesdas, dari Riskesdas di sini tampak kurang lebih hampir sama. Kemudian di sini kalau kita lihat risk factors-nya, bagaimana beban faktor risiko NCD-nya. Jadi kalau kita amati di sini data di Indonesia dan di Yogyakarta kurang lebih hampir sama, baik untuk perokok harian, untuk kurang aktivitas fisik maupun kurang sayur dan buah. Secara keseluruhan, kurang sayur dan buah hampir semua penduduk. Jadi pesannya kita harus banyak makan sayur dan buah, mulai dari kita sendiri berarti. Kemudian kalau kita lihat sedentary life, ya sedentary life ini di Indonesia, di Yogyakarta, ya ini kurang lebih sepertiga, seperempat dari populasi. Tapi di sini ada data yang kami temukan justru, ya ini sebetulnya kalau kami perkirakan, ini kami ambil dari Riskesdas di DIY, ini tampak tinggi sekali sedentarinya di Sleman, tapi tidak sama dengan apa yang kami dapatkan di HDSS. Jadi kami tebak ini adalah karena keliru melakukan coding. Ya, padahal ini adalah dokumen nasional. Ya, kami juga tidak berani untuk mengkoreksi karena kami tidak punya datanya. Tapi di balik itu kita kemudian perlu untuk berpikir kritis bahwa data-data yang kita miliki harus kita kritisi sebelum kita manfaatkan. Ya, jadi ini adalah contoh bagaimana data yang official, kemudian kalau kita kemudian membuat kebijakan berdasarkan data yang official, itu kemudian harus kita kritisi dahulu. Ya, kemudian ini dari sumber yang ketiga yang tadi kita lakukan tentang systematic review. Jadi dari 130 penelitian, 130 buah paper penelitian yang ada, termasuk gray paper, termasuk peraturan pemerintah kita kumpulkan. Kalau kita amati distribusinya, yang terbanyak adalah penelitian tentang social determinant of health, tapi masih belum menyentuh ke arah intervensi. Kemudian penelitian ke arah faktor risiko, ini ada 73. Kemudian penelitian ke arah morbiditas, jadi kesakitan penyakit NCD sendiri, pengamatan ini ada 15, tentang kualitas hidup, tentang kemampuan beraktivitas, lebih sedikit lagi. Kemudian tentang mortalitas hanya ada 9. Tentang bagaimana melakukan penyelesaiannya, ini hanya sangat terbatas. Hanya ada 17 dan 27. Jadi pesan saya di sini, kalau mau melakukan penelitian, itu sangat terbuka untuk intervensi prevention and management is very welcome because the paper, the study on those area is very limited in Indonesia. Okay, and according to that systematic review, there are some agenda to tackle in NCD in Indonesia. The first one is, yang pertama adalah kita perlu melakukan pengumpulan data rutin dengan lebih baik. Ya, jadi surveillance ini perlu dilakukan dan perlu dilakukan hingga tingkat nasional. Jadi supaya manajemennya bisa menyeluruh, jadi sebaiknya tingkat nasional. Jadi seharusnya mungkin seperti HDSS itu, tapi dilakukan di tingkat nasional, di tingkat di Indonesia, sehingga semua provinsi kita bisa melihat polanya. Ya, kemudian kita bisa melihat prioritas untuk pengendaliannya di wilayah-wilayah mana saja. Dan hal-hal apa saja yang perlu kita kendalikan. Contohnya ini saya ambil, death register. Penyebab kematian utama di Indonesia yang pasti kita belum tahu. Kok bisa? Kita nggak dapat datanya. Nggak ada datanya. Data yang ada itu adalah data dari hasil survei-survei yang ada, yang minimal tidak seluruh negeri. Kemudian data dari prediksi dari negara-negara tetangga kita diprediksikan sehingga ditemukan angkanya. Dan memang yang paling bagus angkanya itu adalah yang ada di WHO. Dia melakukan prediksi tersebut. Kemudian disarankan agar kita melakukan apa yang namanya verbal autopsi untuk mencari tahu semua penyebab kematian. Jadi tidak semua yang meninggal itu kemudian dilaporkan. Kalau dilaporkan, tidak semua yang dilaporkan kemudian diketahui penyebabnya apa. Ya, ini kemudian verbal autopsi menjadi sesuatu yang sangat penting dilakukan, termasuk di negara-negara Indonesia. di negara-negara berkembang termasuk di Indonesia. Kemudian dibutuhkan more evidence-based health policy. Jadi butuh kebijakan yang berbasis pada data-data yang valid, data-data yang bagus. Kemudian yang terakhir adalah better health system responses. Jadi sistem yang bagus untuk merespon non-communicable disease, termasuk mental disorder, termasuk kemudian injury, yang itu bersifat lama atau continuous, bersifat long term. Dan kemudian juga memikirkan prevention and treatment efforts. Jadi tidak hanya pada terapinya, tetapi juga termasuk pada preventif dan promotifnya. Jadi sistem yang ada sekarang kemudian lebih banyak mengakomodasi penyakit-penyakit yang sifatnya penyakit infeksi, yang biasanya kecenderungannya adalah dalam jangka waktu yang singkat. Ya, sehingga tidak siap, kita masih belum siap untuk bisa menerapi, mungkin mengobati mereka-mereka yang sudah sakit kronis, dan juga belum sempat untuk melakukan apalagi dalam bidang prevention and promotion. Jadi mungkin sering kita dengar kalau dari rekan-rekan kita di Sarjito, berapa lama waktu tunggu bagi seorang penderita kanker untuk bisa radioterapi. Ya, ini bisa lebih dari 2 tahun. Ya, jadi contoh-contoh seperti itu yang kemudian mendukung bahwa kita perlu memiliki health system responses yang terstruktur, kemudian terintegrasi pada primary healthcare dan berkualitas. Ya, jadi kurang lebih seperti itu. Ya, tinggal kita mau pergi ke arah mana. Arah mana tergantung pada data yang kita miliki. Kalau kita tidak punya data, berarti intervensi yang kita lakukan adalah tanpa arah. Kemudian mau perginya pakai apa? Mau pakai pesawat atau pakai roda 2? Ya, kalau mau pakai pesawat ya sebaiknya ya directionnya harus yang jelas. Kalau directionnya jelas nanti kita tahu-tahu perginya ke Australia. Kalau ke Australia mengikuti yang sudah dilakukan di Australia nggak apa-apa. Tapi kalau itu kemudian tidak sesuai dengan data kita, maka itu akan menjadi satu permasalahan. Ya, mungkin itu saja yang bisa saya sampaikan pada pagi hari ini. Kurang dan lebihnya mohon maaf. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Fatwa, for enlightening us on the Indonesian context of the NCD. Now, we're going to move to the secondary reactors, and if you remember in one of Sam's slides, he was highlighting that cardiovascular disease was the #1 killer from a global level. So we're going to zoom in on cardiovascular diseases, and to do that, we have with us one of the rising star in cardiology, Dr. Anggoro. Dr. Anggoro, the floor is yours.
Thank you. Maybe I would like also to speak in Indonesia because I want to appreciate Bu Fatwa. Okay. But my slide is in English, so don't worry, you maybe can catch up with my slide. Okay. I'm a clinician from Department of Cardiology, and maybe you know that in this Faculty of Medicine, across the street there is a referral hospital, especially for cardiovascular disease, and I also invite our residents, maybe 5 or 6 residents, to come here among their busy schedule in the hospital. So we plan also to move not only, tidak hanya kita treat the patient in the hospital, tidak hanya merawat pasien di rumah sakit, tapi kita juga harus tahu the problem yang ada di dalam komunitas. Jadi setiap hari kalau kita lihat di poliklinik, in the outpatient clinic di rumah sakit Dr. Sarjito itu sekitar 100 sampai 150 pasien per harinya. Itu di poli jantung. Belum ke poli hipertensi atau poli penyakit dalam diabetes. Jadi kalau saya di rumah sakit mulai jam 9, kadang-kadang pulangnya jam 4. Itu pun nanti beberapa clinician mungkin di rumah sakit lain ketemu lagi pasien yang lain dengan mungkin jumlahnya 60 atau 70. Jadi pulangnya jam 9 malam. mungkin beberapa seperti itu, because the burden of disease is very enormous for our clinician. So we need to look back in the community what happened to the community, why so many people with cardiovascular disease we encounter. Oke, mungkin slide-nya hampir sama dengan dari Bu Fatwa tadi, bahwa cardiovascular disease ini masih menjadi salah satu yang nomor 1 di Indonesia. Kemudian kalau di luar negeri tadi, dari Australia, mungkin dari dunia, menjadi penyebab kematian nomor 1. Terutama penyakit jantung iskemik atau ischemic heart disease. Penyebab lain yang kedua adalah diabetes, COPD, asma, ini juga mungkin masuk ke dalam penyakit dalam, dan cancer. Slide. Oke. Jadi kalau kita bicara tentang penyakit jantung, kita akan bicara yang namanya cardiovascular disease continuum. Jadi 100 sampai 150 pasien tadi penyakitnya tidak sama. Meskipun penyakitnya ini jantung, tetapi penyebabnya ini bermacam-macam. Ada yang spektrumnya masih di sini. Masih hipertensi, atau masih dislipid, atau mungkin masih kenaikan kadar gula yang tidak terlalu tinggi. Jadi masih dalam bentuk faktor risiko. Ada lagi yang sudah sangat advance di sini, end stage. Bahkan pasiennya kadang-kadang masih pakai kursi roda atau memakai brankar dengan kaki yang bengkak atau badan yang sesak. Kadang-kadang serangan jantung di poliklinik itu juga sering kita temui. Di poliklinik menunggu dari jam 7 pagi baru dipanggil jam 2, jam 3-nya sesek, atau bahkan kadang-kadang nyeri dada di poliklinik. Itu juga sering kita jumpai. Jadi ini yang kita namakan cardiovascular disease continuum. Dan kita berharap bahwa intervensi itu tidak harus sampai di yang end stage. Nah, jadi kita sebagai dokter juga, kenapa why the patient have to encounter in this spectrum of disease? For example, when they got the heart attack, kenapa bisa mereka mengalami serangan jantung yang ada di sini? Kenapa kita tidak mengetahuinya hanya di sini, sehingga kita bisa memberikan prevensi di sini sebagai prevensi primer. Kalau tadi hipertensi, kemudian diabetes adalah dikatakan suatu NCD juga, jangan sampai pasien itu nanti mengalami serangan jantung. Jangan sampai nanti pasien mengalami gagal jantung. Karena ini merupakan cardiovascular disease continuum. Jadi ini yang mungkin harus kita pikirkan sebagai klinisi juga, beberapa residen, bahwa kita bisa menangkap pasien-pasien sebagai di sini, sebagai risk factors. Karena semakin pasien itu penyakitnya semakin bertambah, maka biaya yang dikeluarkan akan semakin tinggi. Peralatan yang dipakai untuk mengobati juga akan semakin banyak. Ya, contohnya hipertensi kan paling hanya 1 atau 2 obat. Dengan biaya sehari mungkin tidak lebih dari 1.000. Ya kan? Tapi kalau sudah terjadi gagal jantung, mungkin harus 5 atau 6 obat. Kadang-kadang kalau sudah end stage ini harus dipasang alat untuk memacu jantung yang tentunya harganya mahal. Kadang-kadang ada beberapa yang bercanda bahwa keberhasilan kardiologis penanganan penyakit-penyakit akut inilah yang menyebabkan banyak pasien di sini. Contohnya pasien serangan jantung mungkin 6 atau 7 tahun yang lalu waktu saya masih di penyakit dalam tidak ada itu pemasangan stent kalau pasien serangan jantung. Sehingga angka mortalitasnya 30%. Tapi sekarang kita serangan jantung jam 1, jam 2 malam kita sudah datang. Dalam waktu 1 jam kita sudah datang, kita pasang stent, pasiennya hidup, angka mortalitasnya turun 5%. Tapi apa akibatnya? Akibatnya ini selamat, nah banyak yang ada di sini. Jadi keberhasilan penanganan pun ternyata berkontribusi ya dengan penyakit-penyakit yang nanti akan jadi kronik. Ya kan? Nah, kemudian maybe for you from Australia, maybe there's the difference between NCD in Indonesia and Australia. As you mentioned, there are also ada beberapa penyakit CVD yang khas ada di negara-negara yang berkembang, low middle income country atau developing country. As you mentioned, this is undiagnosed or uncorrected congenital heart disease. Maybe this disease is already very rare in Australia. Recently, we have a conference in advanced country. In there are no more talking about the uncorrected congenital. The congenital already known since childhood and already corrected. So there is no word uncorrected undiagnosed. But in reality, in Indonesia, we still have many. And this disease also one of the cause of heart failure in our hospital and our country. Also the problem of rheumatic heart disease. Maybe in Australia or in advanced country there is no more about rheumatic heart disease. Sudah tidak ada lagi penyakit jantung rheumatik karena mungkin sanitasi, kemudian gaya hidup yang sudah berbeda dengan negara yang berkembang. Tetapi di negara kita ini masih menjadi penyebab utama dari gagal jantung. Ya kan? Bahkan ini operasi paling banyak di rumah sakit itu adalah operasi mengganti katup karena kerusakan katup akibat penyakit jantung rematik. Dan tadi kalau Bu Fatma mengatakan antrian untuk kemo 2 tahun, antrian untuk operasi 6 bulan, bahkan bisa 1 tahun. Saatnya dipanggil operasi, pasiennya sudah gagal jantungnya sudah tambah advance, jadi nggak bisa dioperasi lagi. Ini juga problem juga di negara-negara berkembang. Sehingga tidak hanya CVD yang tadi berhubungan dengan gaya hidup, ternyata kita berhadapan juga dengan CVD yang mungkin neglected ya, maybe considered as a neglected disease, neglected non-communicable disease di negara maju. So saya ingin ini menampilkan karena kita klinisi, kalau kita berhadapan dengan komunitas maka kita banyak biasnya. Kenapa biasnya? Karena pasien yang datang adalah pasien yang sakit, tidak mencerminkan community yang sehat. Sehingga kita mengadakan yang namanya registry. Registry itu registry orang sakit karena yang kita ambil adalah the patient who come to our hospital, so we make a registry. For example, heart failure registry, ya kan? Setiap hari kita memasukkan pasien-pasien yang datang dengan gagal jantung dengan berbagai sebab. Salah satunya adalah karena penyakit tadi cardiovascular, diabetes dan sebagainya. Penyebab yang lain adalah karena penyakit katup, penyakit rematik tadi. Kemudian akut coronary syndrome registry, pasien-pasien yang datang dengan serangan jantung juga kita kumpulkan. Kemudian penyakit arteri disease, peripheral ya. Ini nanti pentingnya adalah kita bisa mengidentifikasikan risk factor. Kita selama ini berasumsi bahwa risk factornya adalah merokok, kemudian diabetes, kemudian hipertensi, tapi itu kan sumbernya dari luar negeri. Apa betul populasi kita itu risk factornya sama? Ini kita yang selalu ditantang. Apa betul Indonesia itu risk factor utamanya adalah hipertensi? Apa betul pasien utamanya adalah diabetes mellitus? Karena kebanyakan pasien kita para petani yang tidak ada hipertensi, tidak ada diabetes, tapi tetap serangan jantung. Apa sama risk factornya? Ini yang kita belum tahu. Kemudian yang sebelah sini, ini tadi kita juga mengumpulkan data pasien-pasien yang neglected. Di negara maju yang sudah tidak bermasalah lagi, tetapi di negara kita masih bermasalah. Seperti kita meregistri pasien-pasien dengan penyakit jantung bawaan yang tidak diketahui atau yang terlambat datang ke kita. Dan yang terakhir tadi kita juga meregistri penyakit jantung bawaan penyakit jantung yang akuisital atau penyakit rheumatic disease. Kemudian untuk jangka kedepannya kita akan kembali lagi ke komunitas. Ini kan data rumah sakit, data pasien sakit. Kita ingin tahu bagaimana bebannya di komunitas. Nanti perlu need to back from clinician to the community, so we know what is the risk factor for this kind of disease. Jadi kita bisa berperan untuk mengurangi burden dari penyakit ini di ranah klinis. Okay, I think this is the last of my presentation. Thank you for the presentation.
Thank you very much, Dr. Anggoro, for illuminating us on the cardiovascular aspect